Welcome, everybody, as we get everyone populated here. We'll take a few moments and I will introduce the topic of the day. Good afternoon, good evening, good morning from wherever you are in the world. My name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association, the home for the big-hearted. And that is why today we are bringing you a new webinar series on what we refer to as our HCM spectrum disorders. And those are other thick heart disorders, including HCM, of course, amyloidosis, Fabry's, HFpEF, Danon disease, and other thick heart disorders. HCMA has always been in this space, but mostly we're known for our work in hypertrophic cardiomyopathy. But big hearts lead to HCM centers around the world these days. And big hearts aren't always hypertrophic cardiomyopathy. They can often have an underlying cause that's not related to the cardiac sarcomere or anything that we know to be HCM, but in fact can be forms of amyloid, Fabry's, Danon's, etc. So this is the first in our webinar series on the spectrum disorders, and we are super thrilled to have some experts from around the world join us to go over a few cases in HCM and amyloid. Could it be cardiac amyloidosis? So I'm going to I won't put the slide up yet because your faces are already here. So I'm going to ask our speakers to just introduce themselves for a little bit and let you know why they think it's important to be here today. So we'll do ladies first. Dr. Michels, would you like to introduce yourself?
Thank you very much, Lisa. My name is Michelle Michels. I'm a cardiologist based in Rotterdam, the Netherlands, so in Europe. And I'm the head of the National Center of Expertise for Inherited Cardiovascular Diseases, including hypertrophic cardiomyopathy, but many other cardiomyopathies as well. I think the big importance is that we learn how to look for so-called phenocopies and really differential diagnose our patients. And I think it's becoming more and more important because we have specific treatments for specific diseases.
I couldn't agree more. Thank you for those opening comments. We'll stick in Europe and we'll go over to Dr. Linhart. Would you like to introduce yourselves?
Thank you very much. My name is Aleš Linhart. I'm a cardiologist running a cardiovascular center in Prague, Czech Republic. And we are focusing on many rare diseases in our department, including cardiomyopathies, including amyloid, hypertrophic cardiomyopathy comes to that, and also Fabry disease. Metabolic cardiomyopathies are one of our priorities, and I'm really excited to be here, and thanks for the invitation.
Thank you very much. And for those of you who follow HCM podcasts and webinars, this is somebody not strange to us. Ahmad, welcome to this new educational opportunity.
Excellent, thank you. Lisa found a way to join my two favorite topics in one. So I'm a cardiologist out of Oregon, Portland, Oregon. I oversee the cardiomyopathy section at Oregon Health and Science University. And like my colleagues, we take care of HCM, but also many other diseases that one can look like HCM or can present essentially with primary heart muscle disorder and disease. And so happy to be here.
Fantastic. I see some of our participants have already noticed that the poll has been open, and this is the pretest poll. And we're going to ask you all to take a few moments and take the pretest, and hopefully we can show that we will be very successful in gaining knowledge and sharing knowledge today by improvements in our pre and post polls. So please take a moment while we go through our first case presentation, and let's share my screen. So we first need to do a couple little business tactics here. So this is our session for today. I'll be your moderator, as I said earlier. This is an educational program funded by Pfizer, but we've created all the content ourselves. You're going to hear 3 case studies today, and we hope that sharing these particular case studies helps you to gain a deeper understanding of how to find amyloid within your HCM programs. We have one disclosure slide for all of our speakers, so I'm going to leave this up for just a moment and remind you that we are really happy to bring educational content to you. For additional educational content, you may also want to look at HCM Academy, where you can get a deeper education on HCM from different perspectives. Okay, I am going to hand the microphone and the pointer or share my controls here with Dr. Masri, who is going to begin the session. And I'm going to hand this over to you right now. Ahmad, you should have control of the slide so you can forward yourself. Any problems, let me know.
All right, thank you. Let's see if this is working. It is. Thank you. So again, thanks all for joining us today. Without further ado, I'll dive into what we have here. Let's see. So we've built this in a way as being case-based, and I have few quick examples. More or less, I hear it all the time that physicians say that it's very easy to separate different cardiomyopathies, and there is really no reason beyond EKG and echo to think about what could the patient have. You could figure it out easily, and I think that could be true. But there are certain scenarios where things are really difficult. You could have more than one diagnosis at once. Especially here, we're not talking about two genetic diseases coexisting. We're talking about a potential monogenic or polygenic disease, and then we're talking about another disease that is partially could be genetic, but lots of it is acquired wild type transthyretin amyloidosis, and so that's why one has to keep really an open mind about this. And this is a real case of a 60-year-old patient diagnosed with hypertrophic cardiomyopathy. And, now that you know why we're talking about this, you might say, well, it's very clear what the echo looks like. While this is correct that the echo has concentric, hypertrophy that is severe, this is a 60-year-old gentleman that has no other signs or symptoms, no nerve involvement, no prior whatsoever things going on. And so he was diagnosed with HCM, but what is the case here that this shouldn't be just easily diagnosed as HCM is that also your pattern of thickening in the septum, but also your lateral wall is really thickened. And when your lateral wall is thickened, you have to think about other phenocopies of the disease, including Fabry, for example, in the right demographic and the right situation, including some other conditions. And so he was actually diagnosed for quite some time before he saw an ad on TV and started doing his own research and said, well, I think I have transthyretin amyloidosis, not HCM. And so he, of course, he got through the workup, which was first MRI that showed this, diffuse hypertrophy, septal more than lateral wall, but still it's pretty severe. I mean, this is measuring up to, I think, 28, 29 millimeters. And then this is the LGE images, which you see in the difference is that in HCM, you have kind of a focal LGE where you have the maximum thickness. In amyloidosis, essentially, you have diffuse LGE everywhere. So this patient had LGE everywhere in his myocardium, which is typically reflective of amyloid deposition more than fibrosis. And then there is a very nice, way of kind of screening easily for more of a myopathic process than HCM is the S wave. So we're used to using E prime and A prime for diastolic dysfunction and for tissue Doppler. But if you just look here above the line, that coincides with the QRS. This is your S wave. You use it a lot for the RV, but people don't use it enough for the LV. You already have it. And if your S wave is below 5 or 6 centimeter per second, when you have a very thick heart with preserved ejection fraction and preserved function, you might have to ask yourself, am I dealing with a pure process of hypertrophic cardiomyopathy, or there is another myopathic process that is causing the ventricle to be really this hypocontractile? And this is an amazing surrogate for basal strain as well. So if you don't have strain, you don't have to say or complain that you don't have strain. You can use this one as well. So this is an example of someone, if he didn't actually see that, not that I'm advocating for ads, I think, that's a different topic, but if he didn't essentially think about this himself, he actually would not have gotten the diagnosis, and, and we would not have been helping him already. He's already now on targeted treatment for the underlying disease itself. All right, so we'll move forward. So this is a case that was pretty interesting and unusual, where someone presents to you, says, my brother was just diagnosed with transthyretin amyloidosis, and I'm really short of breath, and I read my echo, says I have severe LVH. And this was a woman, where you can see here, the echo view is a bit off axis, so you have foreshortening there as well. But really, she does have thickening of the lateral wall, which is, Again, not super common in hypertrophic cardiomyopathy. And so we asked ourselves I don't think this video is playing, but we asked ourselves is this HCM or not, correct? Is this amyloid or not? I mean, and then we got the brother's records and we reviewed them, and he actually did have transthyretin amyloidosis. And they both developed shortness of breath around the same time, which is, pretty interesting. Maybe they're talking to each other and that's how all of this came about. But I would stress again, this lateral wall thickening is what caught our attention. And the patient has obstruction, obviously. Valsalva goes all the way up to 70, 80 millimeter mercury, and the patient is symptomatic. And so we go through our usual workup, but here we also added something else, which is investigational. So our usual workup was an MRI, and the MRI showed SAM with really thickened septum, thickened lateral wall, much more appreciated on MRI than on echo, because echo windows were really challenging with the body habitus and whatnot. But on top of that, we also went ahead and did a PYP scan, which was negative. Also did an investigational PET tracer called ivazumutide, which is a pan-amyloid tracer, which was also negative. And so this is an example of someone where the brother had TTR amyloidosis. The sister essentially has hypertrophic cardiomyopathy. Really, we could not find any other cause that could underlie this. We also did genetic testing, and TTR gene sequence was normal. Remember that you could have amyloidosis on imaging. You could have amyloidosis phenotype on echo and MRI, and your PYP or DPD or HMDP can be negative. These typically happen in patients with certain variants, but also can happen in very early disease. But the more we focus on, it's the certain variants. So
we appear to have lost Dr. Massari's connection. I'm going to hope that he comes back to us in just a moment. Please hold. And I'm going to text him. We haven't had that happen in a very long time. You froze. If we don't get him back in a second, then we will move on to our next talk and resume this when we can establish a connection again. Okay, I'm going to stop remote access. And yeah, he lost his internet. He'll come back. And we're going to move on to our next case, and we will revisit this case. Don't peek. We're going to move on to Dr. Linhart. I'm going to, just in case we have a technical issue, I'm going to keep remote control. I'm going to keep the control of the mouse here. So you just tell me when you're ready to move on and unmute yourself, and we'll continue with our next presentation. He's going to log back in. You're on mute.
Let's move on. So now it should
you.
work. Okay, so I will present to you another case where there were some questions about the etiology and whether the patient has AL over TTR amyloid, and whether the patient could have hypertrophic cardiomyopathy as well. So we'll check it out. So we can move on with our slides, please. So the guy is admitted to a regional hospital for non-ST elevation acute coronary syndrome. He received a conservative therapy on which he recovered very, very quickly. Never had a coronary angiography, but then was complaining about exertional dyspnea. He never had any pain, no presyncope, no syncope in his history, and the patient actually had a history of arterial hypertension, which was very well controlled, and a history that's quite significant for patients with TTR amyloidosis. That's carpal tunnel syndrome, and that can occur many, many years before the patient presents with cardiac issues. In this case, 3 years, it's relatively short. We know that some patients are having this kind of issue 7 up to 10 years before presenting with heart problem. And mild peripheral neuropathy, that again could be or not significant. We know there are many causes of peripheral polyneuropathy. So the question was whether it was related to the disease. We can move on. And of course, we start with electrocardiogram, which we do not only to amuse our patients, but to get the significant information. And in this case, you can see there is a conduction impairment with the first degree AV block, left anterior fascicular block. And as you will see in a minute, this voltage is not particularly low, which is a textbook manifestation of amyloidosis. But in this case, it was not that low, but then remember how the ECG looks and what the echocardiography looks like. Another image that might be interesting for those who are seeking amyloid is so-called a pseudo-infarct pattern. So this is his echo. I hope the video file plays on the left side of the image, but if not, that's not so important because you can see a similar picture you have seen during the previous presentation, and that's diffuse left ventricular hypertrophy. And we are amusing ourselves to do strain imaging. The strain imaging may be quite relevant for patients with amyloidosis. And in this case, it's not that beautiful, but you can see that on the bull's-eye presentation that the basal segments are not deforming very well. They are not deforming at all in the case of the anterior septum. And you can see a picture which is somehow resembling to a cherry on a cake with a good deformation of the apical segments. And this apical sparing phenomenon, when apical segments are contracting better than the middle ones and the basal ones, is not totally specific for amyloidosis, but you can see it quite often in patients with both AL and TTR amyloidosis. So at that stage, we had a suspicion. This suspicion was enhanced. You can see that there is some valvular thickening in the same time, probably some right ventricular involvement. The interatrial septum is thickened, and atria are big, which suggests that the filling is not normal. We can move to another slide. And the filling was really not normal because this pattern you can see on this slide is definitely what we would describe as pseudo-normal filling with E to A prime ratio 16, and this is highly specific for elevated filling pressures in patients with amyloidosis as well as in patients with other type of cardiomyopathies. So let's move on. So this patient, however, was a little bit different to what we are used to see, and this is what you have seen also during the first presentation. He had left ventricular outflow tract obstruction. So unfortunately, the video is not playing, but if you were able to play it around, you would see that the anterior mitral leaflet is bending over towards the septum, contracting the outflow tract, which was reflected, and we can move to the next slide, which was reflected by the obstructive gradient that was addressed around 76 millimeters of mercury, and the Valsalva maneuver went up to significantly higher numbers than that. So of course, if you see that, you're thinking about hypertrophic cardiomyopathy, and this is only logical because this is a feature that's typically described with hypertrophic cardiomyopathy. Let's move to the next slide. So is it amyloid or hypertrophic cardiomyopathy? So we have a lot of red flags here that are suggestive for amyloidosis. The carpal tunnel syndrome, history, this pseudo-infarct pattern on electrocardiogram, apical sparing, and interatrial septum thickening, and relatively advanced diastolic dysfunction. Hypertrophic cardiomyopathy, however, is also possible because this dynamic LVOT obstruction, of course, is suggestive of that. So we have to dissect this, and we have also to dissect if the patient has amyloid, what type of amyloid this patient has. Let's move to the next slide. I would like to get back to the apical sparing phenomenon and to show it in more details. And this is something you rarely see that pronounced as in our patients, in patients with hypertrophic cardiomyopathy. And you can see this difference in deformation. This is another patient, but I would like to stress it out because we love to use this parameter. And unlike many other that were suggestive to be specific, this one is quite nicely working. We can see on the next slide another presentation of this pattern. Again, you can see this cherry on top of the cake, and how bad the deformation of the basal segments could be compared to the apical segments. So let's remember that it's relatively easy. You don't have to have particularly good imaging if you want to do a strain. Usually it's necessary to have very good quality of images, but this is working even in a relatively mediocre quality of images. And we should remember that when investigating patients with left ventricular hypertrophy. Let's move to the next one. So this is taken from current European guidelines that were published only last year. And you can see that the first line investigation after having some imaging, and I will get to the question of magnetic resonance, whether you really need it in this case or not. So the first step is on one side to do hematologic tests. Why is that so? Because AL amyloidosis, which is the second most frequent type of amyloid, has positive serum free light chains, a disbalance between kappa and lambda chains, and you can prove it by that, and also by serum or urine immunofixation. Of course, we used to test the different other tests to prove amyloidosis. But this is quite enough to make a differential diagnosis. However, we should remind ourselves that a lot of patients with monoclonal gammopathies that are relatively benign exist. So the positivity is still not fully suggestive of AL amyloid. We should keep that in mind. So that's why there is the second test, and that's bone scintigraphy. Let's move to the next one. And let's start with a hematologic test in our patient. You can see that his renal function was normal. His BNP was elevated, troponin was elevated, but there was no monoclonal gammopathy. So free light chain ratio was normal. Serum immunofixation was negative. We should see that this is really important. If you want to have a suspicion for AL amyloid, you have to have this positivity of those hematologic tests. Otherwise, you can basically exclude it. Let's move to the next one. So why another imaging? Why MRI? Can we dissect it? Can we really see whether the patient has AL or TTR amyloidosis? So of course, MRI is very nice to have because you can see a very typical picture. You have seen already one in the previous presentation, this diffuse LGE. You can have also a picture like on the left side, this subendocardial diffuse circular LGE. You have an aberrant dynamic of gadolinium during the scanning, so difficult nulling of the images. So all this is suggestive of amyloidosis, but it doesn't allow you to see and to say this is AL or TTR. So you need another test, next one. And that's a bone scintigraphy. You can see that different tracers can be used. We are using in our country a DPD scan. And that was exactly the case we did. But before getting to the results, I would like to remind us on the next slide that this is why we are using this test. So if you have AL amyloid or other types of amyloidosis or no amyloid, then usually you don't see an accumulation of DPD. And if I'm saying usually, that's not completely true because we have around 8% of patients with AL amyloid who can still accumulate TTR bone tracers and DPD, for example, within the myocardium. So that's a kind of a gray zone. So not enough to make the diagnosis, but still there is a gray zone. But the positivity is usually typical for transthyretin amyloidosis, like on the left side of your slide. So we are using a scoring system. Next slide. So we are gradually comparing the density of accumulation to the bone density, and you can see that there is a grading which was named after Dr. Perugini from Italy. And if you have grade 2 or 3, so the accumulation is very dense and it's equal to RIP uptake or greater than the RIP uptake, as on the right side of your slide, it's highly suggestive for TTR amyloidosis. Let's move to the next one. So our patient had a bone scintigraphy in another hospital, and it was a grade 3 density of his myocardium. So together with those negative hematologic tests, so it was suggestive of TTR amyloidosis. And then came the question, so are we done? Because if you go through the diagram, which is published in our guidelines and also was published in the position paper of the European Society of Cardiology Working Group on myocardial and pericardial diseases, you are almost done with diagnosing the TTR amyloidosis. But then came the insurances of our country and said, okay, but the guy can have in the same time hypertrophic cardiomyopathy. We are not so sure, and we are not so sure we can agree with the reimbursement of the targeted therapy. So we would like to have something more and more evidence that this is really the case. Next slide. So as I said, you can really stop here in the daily practice. So positive grade 2 or 3 cardiac uptake, negative serum free light and immunofixation, you can say TTR amyloid, but you still are not able to say this is 100% not an overlap between hypertrophic cardiomyopathy and amyloidosis. You can also decide on invasive diagnostics, and if you are not sure that you are in phase of the typical amyloid, endomyocardial biopsy is still a viable option. Of course, it should be done and by skilled operators. The myocardium is relatively fragile in amyloidosis, and perforation is not an unknown complication of those procedures. So let's move to the next one. So that's why we do it under the guidance of the echocardiography. Here you can see the dense line in the right ventricle bioptome, which is directed towards the septum, where we know we can't do much damage. And the result was on the following slide, the histology, and you can see congruent staining on the left side and immunohistochemistry showing TTR amyloidosis and no other signs of hypertrophic cardiomyopathy. So of course, if you think backwards, and if you think why MRI would have been beneficial in this patient, of course, there would be some clues for diagnosing just TTR amyloidosis or amyloidosis in general and not hypertrophic cardiomyopathy, like, for example, prolongation of T1 relaxation time and expansion of extracellular volume. But this is a definitive proof with no discussion about the etiology of hypertrophy in our patient. So let's go to the next slide. So what happened to our patient? So he was finally approved for reimbursement of tafamidis, stabilization of tetramers, of amyloid, of TTR amyloid, which was proven to prolong life of our patients. And since September 2023, he's treated with that medication. He's got also other cardiovascular medications, as you can see here. He's hemodynamically stable here, class 2. We are not expecting major or miraculous improvements, but we are expecting that the patient stabilizes, and that was the case. So, of course, the patient has still a possibility to fix his left ventricular outflow tract obstruction, possibly in our country by septal reduction therapy using alcohol ablation. Septal myectomies are not so frequently used, but so far the patient stays with acceptable symptoms and not proceeding to that. So with that, I would like to conclude my presentation, and I would like to say that in this case, we have seen quite a typical personal history with red flags in carpal tunnel syndrome. The patient may have other red flags like bicep tendon rupture or spinal channel stenosis, which was not the case. The ECG is not specific for the amyloid type, but it should be evocative of amyloid. And I was pointing out on the discrepancy between the degree of hypertrophy and the amplitude of QRS complexes That should be another red flag we are using. Imaging, again, does not fully allow a distinction between the two types of amyloidosis, but the hematologic tests together with bone scintigraphy do, and this is the part of our algorithm. But if you are not sure, there is still a possibility of endomyocardial biopsy. And of course, the end of line, if ATTR is present, the gene sequencing should be done. That was negative in our patient. So he's got so-called wild type TTR amyloidosis. With this, I would like to thank you for your kind attention, and I'm looking forward for any questions.
Fantastic. As a reminder, the pre-test poll is still open. I'm going to close it in just one moment. So while we're transitioning back to Dr. Masri, who has joined us again, thanks to the internet gods for reestablishing connection. If you who have not taken the pre-poll would please do so while I queue up his slides, and you can watch me go backwards in time. So just give 1 minute here. Thank you very much, Dr. Leinhart, for that presentation. And I'm going to guess we left off about here. So I'm going to take care of the slides just in case that was the problem, and just cue me and I'll follow along. So let's go back to, do you want to go here or do you want to go one ahead of this?
One ahead, please. Sorry about this technical issue. One more.
Yes,
All right.
that's where we.
So this is another example of just sometimes keeping an open mind. I think this is one of the rare ones. I just wanted to show you this so that you think also about how the images look like, as well as how the patients are feeling at the same time. This is someone who was sent to us with nephrotic syndrome, very severe proteinuria, clearly renal light chain amyloidosis, biopsy proven from the kidneys. And while the biomarkers suggest that they should be sick, they actually were doing quite well clinically, which is a red flag, correct? Because, you know, in a way, in light chain amyloidosis, if someone has these variables or markers, they actually should not be doing okay in a way. And so the echocardiogram here is a frozen snapshot, had LVOT obstruction, had SAM, and has had severe MR or moderate to severe MR as well. That is SAM related. And so the question was, you know, could this just be amyloid, which is possible. There are scenarios, very rare, but where amyloid can present with LVOT obstruction as well. And whether you have an isolated condition or two diseases at once, we just simply, it's very hard to prove one or the other. But in this scenario, we did our investigational PET tracer again, which shows you that the kidneys are lighting up. So on top of the biopsy, we show how the kidneys essentially having an uptake of the tracer. One more, Lisa, to show some more pictures there. And so these are some more pictures. The MRI essentially showed the hypertrophy, but did not show any LGE, which is again, you know, another point there. And then the investigational PET tracer did not show any uptake. We were comfortable at that point to actually say that this patient had renal light chain amyloidosis and had hypertrophic cardiomyopathy. She was genotype negative, but we didn't feel that we need a biopsy at that stage because, you know, we've done 3 different types of tests that show clearly that the patient does not have cardiac amyloidosis. And this does matter. One reason is that this patient was going to be enrolled in a clinical trial for cardiac amyloidosis, and she didn't have cardiac amyloidosis, she just had renal amyloidosis. So that's one example of why this is useful and helpful. The second example is she will require follow-up. We've been discussing if she wants to consider essentially treatment for her, you know, mild shortness of breath, and she decided not to until she gets taken care of the light chain amyloidosis. So this is really important, in my opinion, to find out what exactly people have and what kinds of diagnoses they have. Next slide. So why we're getting into this trouble? It's because we're using a phenotype-only approach nowadays. We used to biopsy everyone that we have concerns about having amyloidosis, but now with the introduction or reintroduction of a lot of these bone-avid tracers with MRI, with whatnot, and sometimes echo techniques, you are relying on the phenotype. So unless you see lots of these patients, you might actually get it wrong sometimes. And even people who see these patients all the time still sometimes get it wrong because, you know, some of these conditions are fairly difficult to pinpoint down. Next slide. And so which clinic sees the patient is also a problem, correct? Because there are clinics that are only focused on amyloidosis. There are clinics that are only focused on HCM, and that introduces lots of challenges there. We're not taking a holistic view of the patient. Sometimes, I have seen this so many times where a hematologist would write to the patient, you have no evidence of systemic light chain amyloidosis, and they just discharge him from the clinic. But the patient has transthyretin amyloidosis, for example, and no one worked it up, no one started them on treatment. So I think you have to think beyond the singular disease that sometimes we end up taking care of once we focus in our specialty. Next slide. And that's essentially the point, is that it's not a minor list for hypertrophic phenotypes. And the question is, do I just rule out amyloid? Do I rule out HCM, or actually diagnose the patient with the disease? And I would argue that all of us, our primary duty should be to diagnose the patient with the disease, even if it's outside of our area of interest or focus. Next slide. Strain already been talked about. I just wanted to put this study up here as a reminder that while apical strain pattern is useful, it's not pathognomonic, it is not diagnostic on its own. You do miss lots of patients with amyloidosis in the absence of it, and you do sometimes have it present in the setting of aortic stenosis, in the setting of some other diseases when you don't have amyloid. So it's very useful. Use it, please, but also look at the whole picture overall. Next slide. We already talked about the S-wave, so we can skip that. And so that's the pretest probability. Is it low to intermediate, or is it high? People always get confused. Well, I don't want to really image the patient with every single imaging modality that I have, which is very fair. But if your pretest probability is low to intermediate for amyloid, please go with a phenotype first approach, doing cardiac MRI, considering genetic approach and whatnot. But if you have a high pretest probability, you ought to just go directly to the workup of light chain amyloidosis rule out and bone scintigraphy. If you take all of your low pretest probability and do this approach, you're actually going to have lots of problems in terms of, intermediate workup, in terms of, maybe positive, maybe negative bone scintigraphy and whatnot, and that can introduce lots of challenges. Next slide. And so to conclude, HCM is common, hypertension is very common, and amyloid is becoming more and more common. Please try to explain all left ventricular hypertrophy in your practice. It is not normal to have LVH. And then many causes are outside of amyloid, outside of HCM, but they are treatable, potentially treatable causes of heart failure and death. And so resist the anchor bias when you meet a patient, and integrate the clinical scenario with the imaging as well as the genetics if they are available to you. Thank you.
Well, thank you very much. And last but not least, we're going to take a trip up to Amsterdam. And we're going to go through these slides again. Sorry about that. But we're definitely happy that we had Dr. Masri join us back again. So I'm glad the internet came back up. Okay, Michelle, it is your turn to talk to us about amyloid and HCM. And then we'll have a discussion at the end. So add your questions now. And remember, I'm going to close the poll now. Okay, continue, please.
Thank you. Can I proceed my slides, Lisa, or you want to?
I'll take them just because I'm afraid of technology.
Okay. Yeah, so I brought a case from Erasmus Medical Center. It's a male, he's 71 years old. He had a, not so remarkable medical history. I think the only thing that was remarkable, that he was previously known with hypertension. He was treated with an ACE inhibitor, and that actually was caused in the year we saw him because he had complaints of dizziness and low blood pressure, and his ACE inhibitor was reduced in dose and later on stopped by us. And then he was hospitalized for heart failure with pulmonary and peripheral edema. He was treated with diuretics. And he was referred actually to the Erasmus Medical Center after echocardiography and CMR showed left ventricular hypertrophy, and the referring cardiologist thought, what's going on with this patient? And then when I saw him, he had dyspnea de 4 in near class 2 and dizziness upon standing. He had a negative family history for cardiomyopathies, for sudden cardiac death, for amyloid, for everything. He had a relatively low blood pressure for a 71 years old that was previously known with hypertension, so 100/65. There were no murmurs, no pulmonary edema, and no pulmonary rales, and mild peripheral edema. And then we're going to move on to the imaging. So this was his ECG. So he was in sinus rhythm, and for a patient that we were already knew was known with left ventricular hypertrophy, we don't see any signs of left ventricular hypertrophy on this ECG, so that should make you wonder what's actually going on. But you do also see that there, especially in the inferior wall, but also throughout the anterior leads, there are signs that could indicate a previous myocardial infarction, but his coronary arteries were normal because this was already checked. So then we go on to the echo. Oh. Yeah, probably these are also not moving, but it isn't that much of a trouble. So on the left side, you see the apical four-chamber view, in which you see, clearly left ventricular hypertrophy. And if it was moving, you could also see a reduced ejection fraction. And then on the short axis, personal short axis, you can nicely see the hypertrophy as well, and a reduced ejection fraction, but you should just believe me because we can't see it. So if we proceed to the next slide. So this was the CMR that was provided to us from the referring hospital. And we thought, this LGE pattern was very suspect for cardiac amyloid. It has been, I think, pointed out by the previous speakers as well. But what you also can see on this CMR is that you also see some thickening of the intraatrial septum, and you see some pericardial fluid. I think these are all things that could pretty well point out in the direction of cardiac amyloid, as was the T1 mapping that was done and not shown here, but there was an increased extracellular volume. So, actually what we thought there, probably this is a case of cardiac amyloid. So we continued. Yeah, this should be, so this was, I think, so this is the three-chamber view from the CMR, and this actually made us question a little bit, because you clearly can see that the hypertrophy is not, it's not really concentric. The apex seems to be relatively spared. There are also some, irregularities, which we sometimes see in other forms of cardiomyopathy. But then we continued with the next slide. So you already saw this diagnostic algorithm. So we have signs and symptoms, ECG, echo, CMR, suggestive of cardiac amyloid. So I think the first thing we did our hematologic test, and we also performed a bone scintigraphy. And I think what's important, and I'd like to point that out, is that we make sure that this patient isn't suffering from AL cardiac amyloid, because this is very, in most cases, very rapidly progressive. And I think as cardiologists, I see it as our duty that we actively search for this disease, and don't, for example, what sometimes happens, refer the patient to a hematologist with the question, can it be AL amyloid, and not search for free light change yourself. It's quite easy to do, so just do it immediately and ask for a bone scintigraphy. So that's what we did. And it's in the next slide. We didn't have no monoclonal proteins. And I think on the bone scintigraphy, we saw a clear pyrogeny grade 3. So, we thought, okay, this is cardiac amyloid. This was a couple of years ago, where we didn't have any specific treatment yet available. We only had a patient support program, but we went back to our diagnostic algorithm. That's in the next. And then you can click one further, because this is actually where our patient is. And then we said, we have to do genetic testing. And then we sent the patient to our clinical geneticist, but not the clinical geneticist that we normally work with. So what they did, they said, I do a cardiomyopathy panel. And what we found was that there was no DNA variant in TTR. But what we did find was there was a pathogenic DNA variant in myosin binding protein C3, which is in the Netherlands the most important cause for inherited hypertrophic cardiomyopathy. And then we ended up a little bit in a problem because we liked this patient to enter a patient support program, but we also had the result of this genetic testing. And then we were questioned whether or not this was cardiac amyloid or this was hypertrophic cardiomyopathy. And although we said, well, non-invasive imaging, the whole case resembles cardiac amyloid, but then we continued and we did we decided to do a cardiac biopsy. And I don't have this really nice images that Alice showed us, but what we did see in this cardiac biopsy, there was cardiomyocyte hypertrophy, which could resemble hypertrophic cardiomyopathy, but we didn't find any myocardial disarray. There was fibrosis, but there was also positive congruent staining for amyloid. And then we said, well, this patient, the main cause of his problem is amyloid. And we were able to put him on tafamidis. We stopped his ACE inhibitor. We introduced an MRA, spironolactone, and we started tafamidis initial on their patient support program. And then in the next slide, you can see the results of the treatment. Well, especially the NT-proBNP, because actually the patient did well for 3 years, but then he got worsening of his heart failure, rising of his NT-proBNP, and he died after 4.5 years of heart failure caused by cardiac amyloid, but maybe also his inherited hypertrophic cardiomyopathy caused some of the problems. So yeah, lessons learned. I think what we learned is that you can have 2 causes of left ventricular hypertrophy in one patient, so 2 rare diseases. Broad genetic testing using a cardiomyopathy panel actually led to confusion and made us do a cardiac biopsy. We also had so we lost some time there as well. We were able to introduce a specific treatment for cardiac amyloid. We had a lot of discussions on what was the advantage of doing a cardiomyopathy panel or just do focused TTR and inherited amyloid testing from a genetic point of view. Our clinical geneticist says, we have there's a lot of advantages for the family, because we now know that this is also a family with inherited hypertrophic cardiomyopathy. Yes, I think that's true, but in this patient and in this family, it led also to, really a lot of questions and a very unhappy family at the beginning. They're a little bit better now, but we decided to do, if we think from a imaging point of view, a phenotype point of view, that we're really thinking in the direction of cardiac amyloid, that we use our specific amyloid panel. And then I think if you click one more time, then the CMR comes up, because actually when we went back to the patient and looked at the CMR, then and I would like to hear Ahmed, it's not running, but our CMR cardiologist said, there were some signs of probably more familiar with inherited hypertrophic cardiomyopathy than with cardiac amyloid from the beginning. So yeah, I think it's a complex case. This is just what's happening, and even in a referral center, a center of expertise, you end up in these strange cases. And I think we learn a lot from those cases. But I think I do agree that the CMR, and I already saw Ahmed nodding as well, that there were some signs from another cause of left ventricular hypertrophy in this clear case cardiac amyloid. So that was my last slide. There's another slide showing our beautiful hospital in the beautiful city of Rotterdam. So if you're in the neighborhood, please visit, always welcome. But this was the finishing of my talk, and I think we can have still some time to discuss the cases.
Yes, we have some time to discuss. I'm going to go back to that image, because I think that's a really provoking image that a lot of HCM physicians, and we have some comments from one of our Centers of Excellence here in the United States who's watching, like this is a really, like we would see this a lot, this kind of an image in HCM, but going through that differential diagnosis, algorithm was really helpful here. So let's just discuss, how often is this happening in the real world in your experience? We'll start with Ahmad and then we'll bring in Alice.
So I think it depends on your practice, correct? The more focused your practice is, actually, this does happen, not uncommonly. And we have had pathogenic variant proven HCM that developed cardiac sarcoid during follow-up. We actually had quite a few of these. We've had essentially HCM following for 20 plus years, and then suddenly they fell off a cliff, and it was amyloid just developing on top of HCM. We've had a patient, the only reason why, so I do, for example, serial NT-proBNP in patients with HCM who are stable. And we've actually picked up on a few where the NT-proBNP doubled into the thousands sometimes, and they just felt much worse. And that was a signal that maybe there's something else happening. And so these are common diseases, at least HCM and hypertension, and transthyretin above the age of 70 is becoming also like reasonably encountered. And so things will develop as we follow up these patients more and more. I think here the point is, you can see there is the usual belly of muscle in the septum, and then there is abrupt essentially tapering of the septum down there, and then you have the thickened lateral wall. I think when we talk to our fellows, I will say that if the lateral wall is thickened, you have to exclude other diseases with HCM. It can happen with HCM, obviously, but if it's really thickened, that's always in a way a red flag that you should consider others. But brilliant case and very nice images as well.
Reminding everybody again that the post poll is on, and we do have a really interesting question. So everybody get ready to think about this one. Light chain amyloid with, I'm sorry, I don't have my glasses on, nephrotic symptoms, sorry, and LVH, with LVOT, with septal contact, with negative non-invasive cardiac imaging for cardiac amyloidosis. Do you feel comfortable with a myosin inhibitor?
So I think he's referring, or whoever is writing the question, he or she
Mr. Anonymous or Mrs. Anonymous.
Okay, all right, anonymous. So they're referring to the case that I showed, which, honestly, I have no problem using a myosin inhibitor, because a reminder that the patient only had renal light chain amyloidosis, and myosin inhibitors are not renally cleared. They essentially are metabolized in the liver. And so as long as they don't have liver amyloid, as long as they don't have abnormal LFTs and advanced disease, then that could happen and could be done. My preference would be not to do it that way, which is what we have done. My preference is essentially to treat acutely over the first 4 to 6 months and tell them that they're going to be short of breath. It's okay. They just have to hold on, and then get rid of that plasma cell clone, decide if they're going to be stem cell transplant or not. And at that point in time, consider which therapy we would want to do. Before the myosin inhibitors, we used to use disopyramid all the time for these patients, as long as there is no interaction, obviously.
Dr. Leinhart, what do you think about myosin inhibitors in these patients, or the complication of that differential?
Yeah, I agree with that. In that particular case, where you have no evidence of amyloid cardiac disease, then, well, you may suppose this is hypertrophic cardiomyopathy, or at least it fulfills the definition of hypertrophic cardiomyopathy per se. So of course, in this case, it is possible. But I would like to remind us that this is not the case when we see amyloid in the heart, because it would have appeared probably on the slides of Michelle that those patients have frequently a tendency to decrease ejection fraction. Quite a substantial proportion of patients with TTR amyloidosis, up to 40% of them, may have a decrease in ejection fraction already at the baseline. And as I've shown, this is not so exceptional case. It's a rare case, but not exceptional case of LVOT obstruction. So people may be tempted to try myosin inhibitor here as well. But I don't think we have enough data about safety here, so we should be pretty sure that we are not on a thin ice here, and probably not use them so far. There is no evidence that it would be safe in those patients.
A topic for discussion. If anybody else has any questions, this would be a good time to place them. We're going to have about 4 more minutes. There was a previous publication by Ethan Rowan on their HCM experience and looking at their non-obstructed patients and finding 6% of the non-obstructeds that they had labeled HCM were actually amyloidosis. So that was a big wake-up call to the community that even in a very high volume program, they were mislabeling. But we're not really talking a lot about the obstructed patients because we think we're just really dealing with that obstruction. Do you think there's more amyloid hiding in the obstructed population and we haven't figured them all out yet? Provoking question.
Yeah, I'm not quite sure, but we also did see left ventricular outflow tract obstruction in cardiac amyloid, although I think it's rare, but we also did see left ventricular outflow tract obstruction in patients with Fabry disease. So, you know, I think for me the most important message is, if you see left ventricular hypertrophy, whether or not it's with or without obstruction, please do deep phenotype your patient. Don't stop with your echo.
I would completely agree. And as part of our onboarding of the patient community, when they come to the HCMA for services, we explain to them that getting their differential diagnosis is the place to start. So go to a high volume center, get great imaging, get people who understand these anatomies, and get your genetic testing done. And if we can identify those with genetic markers for a particular pathway, that is so helpful in today's world. And I really hope that we get to a day where all thick hearts get that really deep dive, why is your heart thick question, and we all do our best to come to that proper diagnosis, because we are living in a time with more therapeutic options than we've ever had before. And we want to make sure everybody gets the right treatment to sustain life and quality of life as long as possible. So I don't have any other questions here. So I'm going to save you 2 whole minutes. Final shot. Oh, yes, I have to show the final slide. Thank you, Stacy. All these technical issues I got to remember to do in a CMA course. Okay, so for your credits, you've gotten to the important part of the presentation. So you can scan your code right here, or we will email you this afterwards. You could select, could it be cardiac amyloidosis, log in, set up your account. If you have an existing account, you can use that. You complete the verify and complete the activity evaluation. And after completing the activity, you can download your CME certificate, which you will be able to store and retrieve later. The website will be remaining open until October 17th. So if you have missed the entire presentation, it will be enduring assets elsewhere. So you have until October 17th to get your credits, and you can return to the site at any time to download your certificates. I have done my CME job with 1 minute to spare. So thank you for participating in this, the first in a series of our Bighearted community education, and that is going to be the differential diagnosis of HCM and all of its phenotypes. So stay tuned for more in this series coming up in the next few months. And a big shout out to our entire team who helped build this program. Stacy and Julie, who are behind the scenes, Elena, who helped with the grant, and of course, our thanks to Pfizer for funding this educational opportunity. With programs like this, we hope to identify more people and restore their health and give them the treatment options they deserve more effectively. So I thank you all for joining today, and I look forward to working with you all on these problems and solutions that we're all creating together. Thank you very much and have a great day.
Thank you. Bye.
Bye-bye. Call.